Welcome everybody to the webinar. Tuesday. Having a little bit of a heat wave right now in Iowa City, but I hope the weather is just perfect wherever you are. Getting to start the webinar. So welcome everyone. This is Mercedes Byrne-Klug with University of Iowa School of Social Work, welcoming you to today's Nursing Home Social Work Network webinar series. I'm hearing background noise from somebody's phone, but that's all right. So welcome nursing home staff members and supporters of enhanced psychosocial care for nursing home residents. That's what this webinar series is all about. We really are trying to prepare and support people to provide the best psychosocial care possible for nursing home residents and their families. We have two ongoing webinar series, kind of what we call our Tuesday webinar series and our Thursday webinar series. And so once a month on a Tuesday, we have something called the Best Practice webinar series, and that's actually learning practice skills and getting more practice with skills related to psychosocial services in the nursing home setting, and we'll be including a case study in each of those. And so today, hopefully you've read the case study, and if not, we'll go over it real quickly as part of the presentation today. And then tomorrow we will post answers to the case study, so you can fill in your own if you'd like to today, and then see what our presenters have listed for other possible answers. And we are also looking for BSW level nursing home social workers who will be willing to present a case as part of one of our upcoming webinars. So if you're a BSW level nursing home social worker and you're interested in presenting a case or helping to present a case, please email me. Our Thursday series will be providing background information about the nursing home setting. So we've got coming up in a few weeks a briefing on the Affordable Care Act and what that means for nursing homes, and a lot of background information on that. Being part of the live session right now, and those of you who are listening through your computer, to communicate with us, please open up a chat box if it's kind of a logistical issue. And if you have a question that you would like the presenters to address, please open up the Q&A box. It's the very bottom of your right-hand column, and just submit your question there. And as the host, I'll be skimming those questions to give them to the presenters at the very end of the session. The session is being recorded, and the recording will be available tomorrow. It'll be posted on the network's website. We're in the middle of the welcome right now, and then we have the introduction of our topic and speakers coming up, and then the speakers will present until the top of the hour. So they'll present for about 55 minutes, and then we'll conclude with 15 minutes of questions. So right now it's 1 o'clock in the Midwest. The speakers will talk till 2 o'clock in the Midwest, and then we'll have questions and answers till 2:15, and it's an hour later on the East Coast. If you need to leave for whatever reason, please know that you can check out the recording to find out what you've missed. I'd also like to recognize and acknowledge the generous support from the Retirement Research Foundation. They're paying some of the costs to help us make these webinars available. I also want to push out to the members of the National Planning Committee who've been helping to develop these webinars. And to introduce our speakers, we have Robert Conley, Bob Conley, social worker with 20 years experience at CMS, the Centers for Medicare and Medicaid Services. And in fact, Bob was the project officer for the MDS version 3.0. So if you have any questions about that, he can let you know about what happened behind the scenes as well. He's been a steadfast planning committee member, and he's the co-leader of this webinar project. And so, Bob, I'm going to hand the microphone over to you to introduce our topic and our speakers.
Okay, thank you so much, Merce. And as Merce said, I worked at CMS with national leaders, and the important thing that I recognized was psychosocial care in nursing homes really stepped up with the AS 3.0 and how can we help not only social workers in the front line, but nursing, activity, and other staff. So this all has more than just social work. It's to whoever's interested. The other thing that Merce mentioned is we have a case, and we have a case on every best practice. You see in the write-up, if you downloaded it, that we have a number of questions that try and look at how do you think through a case and what are some of the issues as you do that. So if there are ways to improve on this format, please let us know if you see we've missed an important assessment or intervention option. So first I'd like to introduce Byron Cordes. He's worked for 20 years in the social work field around medical social work and case management and clinical work with specific emphasis in geriatrics. Licensed clinical social worker in the state of Texas and advanced certification in case management from the National Association of Social Workers. He owns and operates Sage Care Management, a professional geriatric management agency providing advocacy, education, and support to seniors. He was the 2012 president of the National Association of Professional Geriatric Caregivers, and he's published and belongs to a number of organizations, including the American Society on Aging, National Association on Social Work. This speaker is also an outstanding social worker from Texas. Janis Lasser is a social worker specializing in geriatrics. Is a member of the National Association of Social Work and the Alzheimer's. He is currently the Director of Social Work and Admissions at Lincoln Heights in San Antonio. She's the author of a very popular book that's, in fact, on Amazon.com. You promised never to put me in a nursing home, 5 steps to find a nursing home. She's interesting that she came into social work after a career as a New Jersey high school English teacher and fundraiser for Foreign Affairs magazine. Interestingly, she went to the Lady of the Lake University's Wharton School of Social Work, and Byron was her professor and her mentor there. So I was telling Merce that the student and the teacher are now on an equal expert level, and we're glad we'll hear from them. Byron, I'll turn it over to you.
Well, thank you guys, and we're really happy to be here. And Janis and I are both sitting in my office, so hopefully you hear us well. And today we are, of course, going to be talking about case management services and the social work approach to transition of care. And so our objectives, which hopefully you can see, are to review the assessment process for a social worker in a facility, describe social and medical indicators recognizing the discharge level of care, and then to make sure that you understand the psychosocial care of that client. We're going to hopefully identify some best practices for your facility, for you, to deal with dilemmas in discharge planning, and then to understand potentially negative effects of when there are unmet needs. So with that in mind, I'll hand it over to Janis to talk about what is discharge planning.
Thank you, and I also thank everybody for signing on. We're going to really be talking about discharge planning. I'm going to focus really on those fairly new social workers, because many of you I know did not have geriatric tracks in School of Social Work. I didn't have one at the university that I attended. When I decided geriatrics was something I wanted to go into, it was all on-the-job training. Byron was my very first mentor and supervisor for a year, and then I did geriatrics for second year, a third university internship, and decided.
Dan, could I interrupt you for just a moment and ask you to pick up the headset and directly into the phone. We're getting a few messages that the audience is having a hard time hearing you.
Sure.
So get off the
All right, is this better?
I didn't see. Thank you so much. Sorry to interrupt.
Okay, no, not a problem. So for most of us who are in geriatrics, in nursing homes, it was on-the-job training. And we really had to teach ourselves and rely on some of our mentors. But the basic definition of discharge planning, because there is no standard definition that is provided by CMS, the Center for Medicare and Medicaid Services. Basic definition is that it's the process of moving the patient from one level of care to another and ensuring continuity of care. Now, you've all heard that discharge planning starts on admission. Well, that's true. It could also start before admission. If you know somebody in the hospital and they're coming your way, you can get the paperwork from the hospital and review it. You can also talk with a family member and see what it is they expect and see what that patient's needs are going to be. Now, when we start in this business, nobody tells us that, and we have clients in the building, and we find out they're about to go home. And when we start discharge planning, it can be pretty risky because, let's face it, we've all had patients coming into us, and we expect them to be there for a few weeks or a couple of months, and we think we have all the time in the world, and then what happens? The patient decides he's going home after 3 days, and the doctor is going to agree with it. Well, now scrambling to put something together for this man to have a good, safe discharge home and to have everything in place that he needs. So that's why it is so important to start your discharge planning as soon as you possibly can. And always involve your teammates. I lean heavily on my therapy department, the physical therapists, the occupational speech therapists, and on my nursing department. To know from them what exactly the patient needs medically, what is the patient therapeutically, set up to your durable medical equipment. So it has to be an interdisciplinary approach. And I talk a little bit more about discharge planning. Always keep your patient or your resident first. Come first all the time. And you have to involve your family. Effective communication is important, and this is where your documentation comes in. What I learned from Byron when he was my first supervisor in the hospital was, if you don't write it down, it didn't happen. That should be your mantra, along with always put the patient first. Can you have two mantras, Byron? Sure. So it down, it did not happen. You're probably using a couple of forms of documentation that you're not even aware of. You may be using the SOAP, S-O-A-P method, which is subjective, objective assessment and planning. You'd be using the S-bar method and not even know it. That's called situation, background, assessment, and recommendation. If I were you, I would write down everything at the end of the day. Get on your computer and phone call that you had with a family member or an unexpected drop-in family member who just comes by and wants to talk. Try, if at all possible, to write down on your computer at the end of the day, because you never know when you're going to need that information. It's going to come in handy for whatever reason, and you'll have to refer to it. You may not remember to do it for the next day or the next week. Now, I'll use the multidisciplinary approach, as we talked about, and identify your health care services in your discharge planning. If you're new at this, there's a lot of footwork that you need to accomplish. There's home health care agencies out there that want your business. Byron and I always laugh about this. He calls it the last koozie in, or the pen that you received. A People will try to get your business with bringing you cookies and cupcakes, and I know some folks have succumbed to choosing their home health care agencies by how good the cookies are. But you have to get to know your home health care agencies and see which ones are the best and are good fits for your patients. There are also things out there, like visiting doctors and visiting nurses, your organizations, your civic groups. Get to know your hospice companies and how they work. Elder care attorneys, absolutely essential. You're going to need help legally for some of your families with powers of attorney or setting up guardianship. Geriatric care managers, they are the be-all, end-all. They can cover it all for you and really be a wonderful backup. As a fact, after all my years as a nursing home social worker, I still call Byron. I called him yesterday about something. So never be afraid to ask for help. Who the ombudsman is, who's assigned to your building. That should not be an adversarial relationship. Sometimes buildings are afraid of an ombudsman coming in. You really need the ombudsman, and you need to work together. And also, again, involve your whole team. Now, a little bit about the Affordable Care Act, which is also called Obamacare. It's essentially to put consumers in charge of their health care, and it's a federal statute, and it does aim to increase the affordability of care, and that means there is going to be greater need for more social workers. But I'm not going to talk too much about the Affordable Care Act because the next webinar you have coming up is going to focus on that, and I'm going to be signed on to it myself because there is so much that we need to understand about it, so many facets that we all need to be educated on. And I would strongly suggest you all sign in to that webinar on the Affordable Care Act. There are a number of tools you should have in your toolbox, as we call it, to help you to assess your residents. Byron is going to talk to you a bit about that now.
Okay, thank you, Janis. So hopefully you can see this slide up here and talk about the tool for discharge planning. And my opinion is that the social workers do the best is assess the entire situation. Of course, we all should be working from a strengths perspective, but we work with the entire system. And our understanding of the system, the client system is above and beyond anything that nursing and therapy and physicians can offer. So I really think that that's where we have to focus our attention, is that we're in the big picture. That is our strength. And so, of course, should be for discharge planning, you should be doing a complete biopsychosocial assessment. Now, obviously, the biological /physical information you're probably going to be getting from physicians, your nurses, to be very multidisciplinary, the whole situation. On functional status, you're probably going to be getting information, and as Janis said, some of her biggest advocates in a facility are the physical therapists, but also from your own assessment. So I have one of the handouts that we've used is the CATS CATS Index of Independence and Activities of Daily Living, and then the Lawton of Instrumental Activities of Daily Living. And so those two tools are excellent. Physical therapists are saying one thing, but being a different. And so sometimes when you sit down with a family or a patient client, having this in front of you and showing that, hey, look, you scored really horribly on this can help, or you scored really well. One that I've found certainly is that many seniors overestimate their abilities, especially when they're thinking about going home. And I'm sure most of you have already had this happen to you, where the resident can't make it from the bed to the bathroom, 10 feet away, and they say, I'm going to go home alone, where my bathroom is, downstairs and, through the living room. And how are you going to do that? Well, it'll be different because I'm at home. I've always been able to do that at home. And, of course, that's very wishful thinking, but it's oftentimes not reality. And so understanding activities of daily living and instrumental activities of daily living is extremely important for your clients, so that you get a really good picture of their true abilities is very important. And then the second part of the biopsychosocial, of course, is the psychological. You need to rely, hopefully many of you have consultants. You've got facilities have physicians, but then they also have a psychiatric team or a psychological team coming in. And I know, some just have psychology or clinical social workers coming in to do therapy, or they may have a psychiatrist as well, or instead, who are doing medication management. But hopefully many of you have some kind of consultation. If you don't, then, hopefully you have some kind of network that you've built yourself into, because a lot of, in many facilities, the social worker is alone. The therapists have a staff of 2 or 3. The nurses, of course, have, dozens. But you're the lone wolf there in the social work department, so you need that support. But as you're assessing the psychological status of your resident, there's many tools you can use, and we've listed several here. The MMSE, which is the Fulstein Mini Mental State Exam, it's a great tool. It's been around for years. It's very well proven. It's 30. It's based on a system up to 30. I did not include it here because I think most people don't realize that it's now copyrighted. Pearson or Pars, I can't remember the name of the company, but that owns the copyright for MMSE. You let it go out on public domain. As long as people were using it appropriately, they had no problem with it. But I don't even know, 5 years ago, they invoked their copyright. I know tons of social workers who are still using their photocopies of forms of the MMSE, or their own form that they got years and years ago. You could be breaking the law, so please be careful. If you're using the MMSE, the actual Fulstein Mini Mental, then you probably need to make sure you're using the copyrighted version. But there are many other free tools. We use MMSE here in our office, and we buy it on such a limited basis. It costs us about $1 a page each time we use it. Obviously, if your facility is using it more often, you can bring the proper usage down from there. But the SLUMS is another great tool, and again, we've included here. This is in the public domain, and it's the St. Louis University Mental Status, and it also is based on a 30-point. It shows you that if you're the same questions that the Fulstein has on it, are you asking different questions about it's looking at cognitive status. It also includes a clock drawing in it. And so out of those 30 points, the ring is at the bottom, a normal, mildly cognitive impairment, or dementia, and or possible dementia. There's screening tools. They're not diagnostic, but they can help you see if someone is leaning in one direction or another. So SLUMS is a great tool. Hopefully, many of you are also using the depression scale. It's a wonderful tool that is available, and in fact, as I'm thinking through, it shows the page only shows the instructions on it. But the depression is a 15-point scale and a 30-point scale. I'm going to tell you that most seniors, when we tried to use the 30-point scale, catch on pretty quick. It's valid if you're using it on higher functioning folks. If there's cognitive impairment, then the geriatric depression scale actually isn't a valid tool. So if you're using the 30-point, at about 12 to 18 questions, they're kind of going, well, how many more questions are you going to ask me? So the 15 scale is valid as the 30, and I have found that seniors get through it much easier. So you can screen for depression there. There is an app for if you're using Apple products. If you've got an iPhone or an iPad, there's an app for the depression scale that works great. There's also THQ, which is similar to the geriatric depression scale. I'm sorry, but a little simpler to administer. And I'm not seeing attached here. I apologize. I'm not sure, Mercedes, if it's up there.
PHQ is part of the MDS, and so the social workers are familiar with that tool. Yeah.
Well, and that was my next point, was that it is part of the MDS 3.0. So, and Janis and I had discussed that it's the exact same thing, and if you don't work in a facility, so I'm not totally familiar with the MDS. So all of you should be familiar with it if you're using the MDS 3.0. There is the clocks test, which is an executive clock drawing test. It is copyrighted by Donald Roll, 95, and we include it here. It's a very simple tool to use. Instructions are on it. Draw that says 145. Set the hands and numbers on the face so that a child could read them. Do that on the flips on the back side of the page, and that's the clock. And then the clock 2 is when they basically copy the front. And that you'll see someone who scores even a 28. We're crossing 30 on the Holstein Mini Mental, and yet they'll score a 9 on the clocks 1, which indicates that they need an assisted living or nursing home level of care. Basically looking at executive functioning, which is all frontal lobe. So hopefully those are helpful to you all, and you'll be able to use those. Then we talk about biopsychosocial, the last thing, obviously social history, and we include any for that. There are 1,000 different ways to take a social history and assessment. Most time in a bachelor's program, certainly in a master's program, you're going to learn how to take a social history and apply that. But getting as much information as you can, and sometimes we realize that is very difficult in our time-crunched society. That's why I left the hospital system that I used to work for. It felt like we weren't being able to spend enough time with our clients and their families, so we couldn't get an accurate history. We couldn't get an accurate assessment. And then the very thing is follow-up post-discharge. Janis said in the facility they're required to do 100% follow-up after discharge to ensure that the discharge plan is working the way they put together. And so hopefully many of you are also doing that. Once you've done your assessment and you've completed your discharge plan, follow up to ensure that it's continuing to work the way you hoped it would. So the next slide is our challenges, how, this is where we struggle as social workers to make this happen. So I'm going to hand it back over to Janis to talk about those challenges.
Thank you, Byron. I just wanted to make a comment on some of these tests that Byron was talking about. The clocks checks for cognitive impairment, and it checks for cognitive impairment, and it's really being used to test for Alzheimer's. It's very good. Those who don't know, we do the BIMS, 3.0. BIM stands for Brief Interview for Mental Status, and it only is brief, as you know. But it really checks for attention span, orientation, recall. Temporal orientation, the year, the month. Just want you to be familiar with that. And can we say, thank you for the tools, but we're really busy and I'm like crazy around here trying to meet the needs of 110 residents. I don't have time to do any of these. Well, keep in mind that the geriatric depression scale takes 5 to 7 minutes to do. And also note, depression is not a natural part of aging. It's often reversible. So it would behoove you really to try the geriatric depression scale. It does not take a time out of your day. The law tests for 8 areas of functioning take 10 to 15 minutes to do. And the CATS for the independent activities and daily living checks for 6 areas of function. Also takes 5 to 8 minutes to do. You don't have to do all of these tests. They're for you, and they're not terribly time-consuming. Just wanted to let you know that. So on the slide, our challenges, again, focus more on the fairly new social workers or been doing it for a few years and you're still struggling to try to get all your resources together. The first thing you must always keep in mind as a social worker in any field is promoting self-determination. Self-determination, the resident's right to the freedom to make his own choices. That's very important. If they have not been declared incompetent, let them speak. Also remind the families not to speak for the residents. When I have them in my office and I'm asking questions, I frequently have the families jumping in to answer. Until that, it's important to let the person speak for himself and make his own choices. And we know very well, our opinions, the choices may not be good for them, may not be as we would want them to choose, but it is their right. Their right to make a bad choice. You've heard that before, I'm sure, just like we always say in the nursing home, well, it's right to fall. Hard for us to really wrap our heads around. It's his right to fall. We want to keep them safe. But it is a person's right to make their own decisions about their own life, and we can't really impose what we think is best for them. We have to let them have that freedom.
Your voice is cracking in and out. Is there any way they can adjust the sound on that end because your voice
I don't
is
know. I'll have to ask Byron.
Okay.
My voice is cracking in and out.
Thanks.
Huh. Wiggle the wire so much. Let's try it again, Mercedes, okay?
You.
Sure. Thanks for letting me know. Language barriers, that's something else that can be up against these days. And Byron and I had a good conversation the other day about the difference between having a translator and an interpreter. So a translator is really going to give you a verbatim translation, but an interpreter is going to give you the nuances. For example, you ask somebody to translate for you. You may be asking the housekeeper to translate for you. And a lady is telling the housekeeper she has cancer. The housekeeper doesn't know the word in English, pancreas or pancreatic. So she comes up with some other organ or something inside the body. So that's when you need somebody with nuance interpretation of the words that somebody is saying. Your community services I touched on before, but sure that you know about your area council on aging. Every county has it, and they are a treasure trove of information. They help you with what Medicaid has the benefit for people, providing private services for them. They can explain that to you. They can help you to help your resident bus passes. There is also a senior center somewhere that has senior daycare. There are Meals on Wheels. You've got church volunteers. Sure, you check to see if there's lighthouse for the blind in your community, because that is fantastic, and you really need to know what is out there for visually impaired people. Visiting physicians, mobile dentists, mobile podiatrists. So know what's out there. Let's go through. I always call my people after I've discharged them. It's really important. If you get them up with home health care, did home health care agencies show up on time? Or perhaps your residents sent them away. We've all had that experience, decided they didn't need home health care. You just need to know how things are going for them and how they're doing, and if you can continue to meet their needs. I always told my residents that once you're in my nursing home, you're a member of my family, and even when I discharge you, you're still a member of my family. So they often keep calling, even if they've been home for weeks or months, asking me if I can help hook them up with something. Dependence on pharmaceuticals can be a problem. And nursing homes will say, he's yelling and screaming, just give him something to knock him out. Let's first try to find out why somebody is yelling and screaming. Limitations and biases. This is very important. We have our own set of values. What came from our families or our religious backgrounds. We have to be careful not to impose our biases or our values on our residents. We mustn't make value judgments on them. This is difficult, and this really needs practice. And what I urge people to do in my lectures is to make sure you always keep yourself educated on various cultures. This is very, very important. What you might not find acceptable, perfectly acceptable in somebody else's culture, religion, and vice versa. The next slide I found very good to illustrate that point. Take a minute to read that.
We who are listening by phone who can't see it, so.
Okay, all right. So what we have on, okay, Mercedes, thank you. No, some people can't see it. All right, on the left side of the cartoon is a slender white blonde in a bikini, large dark sunglasses. On the right side is an Islamic woman in a burqa. There's nothing showing but her eyes. Passing each other in the street, and they're turning around and looking at each other. The woman in the bikini with the sunglasses on is thinking to herself, everything covered but her eyes. What cruel male-dominated culture. The woman in the burqa is looking back and saying to herself, nothing covered but her eyes. What cruel male-dominated culture. So here you have two women who have different points of view about the same thing, but all dependent upon the culture. So you have to know what's acceptable in some, unacceptable in others. That's very important. And we'll switch over to psychosocial care, and Byron is going to take it from here.
Thank you. So as we address psychosocial needs, at least in assessing them, one that we've noted, certainly in our work, is that most home residents, most of their needs are psychosocial in nature. Their physical needs are certainly being addressed by the nursing staff and the medical staff, but many times their most pressing needs are psychosocial in nature. And so one of the definitions we have here is the psychosocial describes a constellation of social and emotional needs and care to meet. It includes recognition, diagnosis, and treatment of mental health disorders such as depression, anxiety, dementia, delirium, all by the MDS. And so as social workers in facilities or even outside of facilities, it's incumbent on us to address all those psychosocial needs. Certainly recognizing them and diagnosing and then treating them. So almost any time that you run across one of your residents, you should be using the appropriate tools to make sure that their problems are recognized. So, and then of course addressing issues at end of life care I certainly know that being taught at the UC level for both BSWs and MSWs, know that in many BSW programs that counseling is not or therapy is not addressed, but that doesn't mean you can't still address those losses at the end of life. Both the family and as the resident is starting to approach their end of life. So at this time, drawing in those experts, consultants, the psychiatrists and the psychologists, or clinical social workers at your facilities. So the risk factors then for less desirable discharge outcomes start before the person ever even gets into your facility. I think I spent almost a decade as a director of social work, and then ultimately we became case managers in a hospital. And for that decade, as hospitals did a progressively poorer and poorer job of transitioning clients out of the hospital into alternate levels of care, and certainly into nursing homes. So there's always been, and I would argue certainly here in South Texas, it's getting worse, insufficient transitional care planning. And so, you're getting residents into your facilities that less about. You're getting, poor medical histories. You're getting poor social histories. I can remember, seeing the histories physicians fill out, and in the psychosocial part, the physician will literally nothing. And so, you have a client that you have zero information about. The risk, of course, is poor support systems. We're seeing, as our society ages, we've got family members at a huge so we have residents and clients that have little or no support systems. Their families are at a huge distance, or completely non-existent. And that's certainly our current my current company, our care company. That's kind of the biggest population we have are clients with systems. We assist guardians and families at a distance. Of course, cognition is a risk factor for less than desirable discharge outcome. If your client has cognitive deficits, getting them the services, getting them to agree to the right services is very difficult. Even finding the right services, because of course, poor mental health services in the U.S. And then challenging socioeconomic situations. Everyone's had that completely unfunded client that they can't find almost any services for. They go home, or they stay in a facility. They're trying to find a Medicaid bed, trying to find them somebody to take care of a PICC line at home. When there's no funding or poor healthcare coverage. The full care, which I know Janis mentioned earlier, and again on September 26th, which is next in this series, that will cover the Affordable Care Act. As Janis said, she'll be on it so a lot because I think it's so confusing. But should, at least in theory, it's supposed to help alleviate some of the problems with our underfunded or unfunded patients. And then, of course, the multiple health problems, hospitalizations, when you've got that client who is kind of the yo to the hospital and out of the hospital, they have multiple comorbidities. You're trying to help them with every single one of them. The doctor fixes the COPD, but CHF is flaring up. It's very, very difficult. They're uncompliant diabetic. And so all of those multiple health problems start to compound, and then compound certainly in our aging population. Those multiple comorbidities, when you add a fragile cognitive status or a poor cognitive status compromised, then I like to say it's all over but the screaming. So they become very, very difficult clients to work with. I'm going to go over to Janis to cover the last half of these. Hang on.
Thanks, Byron. Challenged residents is something you have to be very sensitive to. If you to be sending someone home, for example, who is visually impaired, they can get into my house. It's been that way for 40 years, and I know everything. What if they're not going home? What if they are going to a personal care home? What can you put in place for that person who has macular degeneration, for example? We know it's all too prevalent in nursing homes. What can you do? This is where I would call on Lighthouse for the Blind. You can go online. You can see what they have in the catalog. For example, amazing things. They have talking cups and talking glasses, so that if you are going to pour a drink into a cup, if you're getting too close to top, it tells you that, and the person doesn't then stop pouring. But they have some wonderful things there you should familiarize yourself with. And also our people, despite the fact that they're into hearing aids, still can't hear very well. What can you do for them? So be sensitive to your people. Mental health issues, and Byron just said it, is not very well addressed in America, unfortunately. I should contact those community services that can help. I just had a case recently where I had to contact the healthcare outside agency come in and help somebody who refused to go to a nursing home, could not go home anymore. We found a boarding home for him that specializes in people's mental health issues. So I've said this before, don't be afraid to ask for help. If you're not familiar with everything that's ask questions and call people, have them come into your office and tell you what we're all about. On clients, we've all seen that. We've seen the man that needs to be on the walker, and he absolutely refuses. He does not want to be seen as an old man. Therefore, he's not to use his walker. You know he's going to fall again. They're right to make those decisions. So how can you help that resident who's going to be non-compliant? You involve the family, and you involve the therapy department and nursing, and you should involve his doctor. Not only addressing losses and grieving residents. Now, this is something that I really focused on a lot. When I wrote that book last year, You Promised Everybody in a Nursing Home, I made sure that I kept it a very positive book on nursing homes, why some people can really benefit from being in a nursing home. Because of their loss, look at it this way. I have a resident who lives was in a very large home that she had been in for 50 years with memories and souvenirs. Now she's lost her spouse. Most of her friends may be gone. The doctor tells her that she can't drive anymore. They're all losses. Children are telling her that they have to move her out of that big house, in a room in a nursing home. And, oh, a minute, not the room, half of the room. There's going to be a stranger living on the other side of that curtain. Well, no, there's so much depression. It's to be expected. But these are all losses for people, and unfortunately, they come so quickly near the end. You have people grieving not only for the loss of loved ones, but for the loss of a lifestyle that they once had. So you have to be very sensitive to addressing those issues, and perhaps need to call in a psychologist and discuss it. And you can do talking with people, but you must be aware of what they're going through, and they're not just they're there now. It'll all be better. You'll get used to this in no time. This is a huge lifestyle change, and you have to be very aware of what's going on with our residents. So that is another risk factor for a less than desirable The people are going back to their homes, or not going back home, but they're going to go to an assisted living. They're going to a personal care home, but it's not their home. That's an adjustment that you need to help them with. We did not receive all the coursework probably as undergraduates or graduates in social work schools that helped us deal with these psychosocial issues. As I said in my opening, a lot of it is on the job practice involving your entire team. So let's take a look at the case study that we're presenting to you. Give you Byron.
So the case study that we have is a Mr. B, a 78-year-old Caucasian male. He has been living in a nursing home for a little over 4 years. He's a guardian who is his niece. He has no biological children. His wife several years before. He's been declining some over the years. He's been in a locked, secured unit for dementia. Was still ambulatory and at risk for wandering. Every time the door would open, he'd get out. And completely redirectable, able to get back into the facility. He was just the environment was dictating his actions. He saw an open door. And he thought, "You're supposed to walk through those." He had we had no problems with elopement. He wasn't trying to get somewhere else. He did have some trouble swallowing and was on a puree diet for about a year. Although he'd been complaining that he would often take food from other residents' trays. Birthday parties and things like that in the facility, he would get a hold of cake. The guard had a problem with this based on his quality of life. She had signed a dietary waiver facility stating that, if he got a hold of solid food, she understood, and that was a risk they were willing to take as not to keep him a prisoner from it. He could, if he got a hold of it, they would understand. He ultimately had a series of strokes, which placed him in a hospital very near the facility. Where he failed a swallow study miserably, and a physician, an excellent physician, I will say probably better than most, spoke with the guardian and presented several options, and leaned towards one or the other. I will argue many times physicians, I think, kind of try to push their own agenda, or well, I'm a surgeon, so we must do surgery. So, but anyway, this physician stated that the tube, probably would prolong life, but I included with his description a lot of the problems that come with a PEG tube. A very conscious niece and a very bright young lady. That inserting a PEG tube would be contrary to her uncle's desires. Though he had written documentation to that, he had never done an advanced directive. The charge nurse, as they were transitioning the client back to the facility, the nurse at the facility strongly recommended they use a PEG tube, thinking that this would, improve his quality of life, having this food. The nurse thought that he wanted that. He presented saying that the client would probably want. When we ended the charge nurse with the fact that this demented man probably wouldn't have wanted a PEG tube, and all of the problems that would come with it, he wouldn't keep his shoes on. How's he going to keep a PEG tube in? The nurse had kind of answers to all of those. They could use a dental binder to PEG tube outside so he wouldn't pat it or pull it out. If the resident had difficulty with the feedings, they could have 2 staff members hold him down while a third did feeding. The good news is that as guilty as the charge nurse was making this niece feel, these that he made led her to decide that, wow, this is really a horrible decision for him, for her uncle. And so she was very confused at first, concerned about appropriate care and doing the right things, and we had literally several days of her being tormented about, I'm having this professional I like and appreciate that he and his staff have provided, and he's telling me I should do it, while my family and my conscience are kind of telling me maybe it's the wrong thing to do. So if you look at the case study scenario that we have, so I have the screen and describe the key elements, which I've just done. So we have number 2 is based on your assessment, state the central problem for the resident staff. So from the resident perspective, I'm sure all of you can kind of think some input. For him, it was really a quality of life issue. The inability for him to communicate his needs. He was nonverbal at this point. And the fact that he did not have an advance directive, we simply had to go off what we would think his wishes would be. He did still have a living brother, he had several nieces and nephews, and then, of course, a guardian who was also a family member. And they would know, we hope, his wish. And so based on that, we are wanting to provide him the best quality of life. From his perspective, desired to do the right thing. Both the guardian and just the close family are receiving conflicting care, guilt-producing information, so it's just confusing them even further. The nursing home, some of the central problems are that certainly looking at their own interest. All have our own biases, and as social workers, I think we're all better trained at kind of reflecting and understanding our own biases and separating out what we would want as opposed to what the client wants in their best interest. So for nursing home staff, they're trying to do something that they feel is in their best interest. They're thinking that can help the resident, but maybe not necessarily what's in his best interest. So the third question here is what are the preferred outcomes and options that we consider? So as the social worker in the facility was instrumental in helping pull everyone together, the preferred outcomes were that the niece, of course, was conflicted and weighing all her options, but what would want to happen is that only consider the wishes of the resident by being a surrogate decision maker. And I think that we all have to be careful about and make sure that we understand as a guardian doesn't get to supplant their decisions into a situation. They are supposed to make, as a surrogate decision maker, they are supposed to make the decisions as if they were that resident. And families should be doing the same thing. So we would ask that she make a decision that he would make. So the fourth question, what are the interventions that we considered to get to those preferred outcomes? So certainly educate the niece, make sure that she understood all of her options. She reviewed with the physician, the GI doctor, about what the tube would mean, kind of the physiology behind it, what it might mean. We actually had her talk to a hospice company. Although he didn't go to hospice initially. That guardian on the different options: the social worker in the facility, in the nursing home, the social worker at the hospital, our care management staff, which is made up of nurses and social workers. And then we had a care plan meeting before transferring back to the nursing home. The social worker in the facility helped facilitate that. We had the social worker, the nurses, the care manager, the guardian over the phone. We had the dietary manager from the facility there. All the ways that we might meet his needs without a PEG tube. And then the one was the question there is, to what extent extent were the interventions effective in producing the desired outcome, and were there any unintended consequences? I would argue that the intervention was very effective. It also says how was the care plan modifications made, or were care plan modifications made? And of course, from initial care, new care plan interventions were made. This man is now mostly ambulatory. He's trying to get out of bed on occasion, so there's a way, keeping safe while unrestrained, giving him nutrition that he wants and or needs. The niece guardian ultimately felt very supported in her decision. Her guilt was almost completely gone, thank goodness. And she did decide to leave out the PEG tube and have her uncle have small feedings at the facility. His swallowing never really improved. He had a couple of more swallow studies while he was back in the facility, and a little conflicting information that he might be able to take some soft foods, some purees, some thickened liquids, and things like that. But ultimately, he had small amounts of pleasure feedings, the thickened liquids and pudding, and the unintended consequence is that he did better than anybody expected. The man lived for almost another 2 years with just small feedings, probably one meal a day. He was fairly, as far as we could all tell, of course, nonverbal. So, and his care plan was constantly modified throughout that process. Ultimately, did end up on hospice towards the very end. What lessons did we learn? Any federal or state regulations impacted? Were there systems or process improvements needed in the facility or in our practice? Certainly, the lesson learned is that education is paramount. An informed decision is always the best decision. So, inform the guardian of all of her options and everything, all of her choices that she could make, and what those ramifications would be on her own, were very important. Any state or federal or state regulations impacted. Certainly, her decision process through the guardianship. They necessarily impacted, but they certainly came into play. The fact that she had the power to make these decisions. Facility did learn from this in that before nurse managers speak, they would have a powwow. They improved their communication across all disciplines and tried to come across with kind of a unified voice as the facility before speaking to family members. And again, her was instrumental in that, in bringing about all of the best practices within the facility. So that's our case study. I'm going to hand it back over to Janis for kind of one last word on self-reflection, and then I think we'll be ready for questions.
Thank you, Byron. Yeah, and just one comment about the study in general. Can suggest things based upon what's available in the medical world. We can make those suggestions. But what is their take on quality of life? It varies from person to person, family to family. Some really just savors food and wants to taste the food. The idea of a PEG tube may not sit with them. It's sometimes quality of life versus keeping somebody alive, just to have them there with you. These are all things that we have to consider on a case basis. So everybody should get as much info as possible from doctors, hospices, citizens. On that last slide, we talked about our challenges, and I think a part of that is the fact that this is one thing, facilities tell us to do something else, and tells us what they want, and that our own values are during this thing. And I talk about in many lectures is self-reflection. It is critical. No matter what you're in, you're home from work at the end of the day. So many people just a little behind. They're out of the office. Oh, thank God they're home and that's done, and they want to be with their families, watch TV. people to take 5 or 10 minutes every day, whether you're on a couch listening to music or you're sitting in the bathtub or it's right before you go to bed. Think about the day that you had at work and did you get the best possible decision day, knowledge that you had at hand. Knowledge at hand is going to change the more and more experience that you gained. But ask yourself, would I have done it differently? Or what could I have done differently? And a lot of your follow-up phone calls will be based on that too, because of feedback from your families. And that's good for future relationships with people. But self-reflection is critical to education. I mean, as a former teacher, I'm always stressing education. Educate yourself to various cultures, to what's out there in your community, to what kinds of assessment tools will make you a better social worker. Self-reflection being absolutely critical, effective practice. So you always must be willing to evaluate what you do, why you do, and how you did it. Makes you a better social worker.
Thank you so much. These are really helpful comments. And we do have a few questions that have come in during the presentation, so I'm going to go ahead and switch to those. There was one comment that said, in my facility we use the MOCA, M-O-C-A, cognitive exam. Is there a reason that that wasn't mentioned, and would it be recommended, would you recommend that I switch from the MOCA to the slums? Any response to that?
I have to say, unfortunately, Janis and I are both shaking our heads. It wasn't mentioned because I don't think I've ever heard of it. So that doesn't mean it's not a valid test. So if it's a valid, nationally recognized test, I would say no. There's no reason not to use it at all. I think it's
if it's easy to administer.
Yeah, it's easy to administer.
It doesn't take a lot of time.
Yeah, and a valid test. If it's truly testing what you're looking for, then use it. Yeah.
All right, and there's another question that came in. It reads, are you doing the cognitive and mood assessments in addition to the BIMS and PHQ-9? SNFs, these are used as part of the RAI process.
Yes, the MDS 3.0, yes. A lot of social workers think that is very time-consuming, but yes, you do a section C, D, E, Q, V. Yes, we do it all. You do the BIMS, then you come back and do the cognitive and the mood interviews with them. Yeah, absolutely.
All right. And then there was a question, in what situations should the following test scales be used? So the scales that you talked about today, what situations would you call for them to be used?
Well, again, this is Byron. I don't work in a facility. I've done psychological work as a clinical social worker in facilities, but I worked as a facilities worker. So Janis might be able to give more concrete examples, but I would argue any time that your gut tells you you need more information. If the BIMS and the PHQ-9 are giving you all the information, and your social history are giving you all the information you need, and you've got a diagnosis of depression from a psychiatrist, you really don't need to do the depression scale again because they've got a clinical diagnosis. But really, any time that you think there might be some cognitive decline, any time you think there might be some depression, any time that you think there might be phobe involvement, you should be using another screen tool or another test.
I agree with Byron because people come in and the nurses, and this is another reason why you have to have close working relationships with your nurses. They'll say, well, Miss Brown has been crying for days, and you look, and Miss Brown has no diagnosis of depression. You go and you talk to her, interview her, you talk to her doctor. She may very well need to have a geriatric depression scale used. You use your judgment about that, but you will know when you interview interview your residents and you spend time with them, you will know if you need to test them further on something. And as I said, even though depression is not a natural part of aging, the majority of residents in a nursing home suffer some degree of depression. So it is a reason why you should use some of these tests, yes.
I'm looking to see if there are any other questions that have been typed in, and I don't see any other questions. And we have another 5 minutes, so if there are other points that either of our speakers would like to make, or if somebody in the audience would like to type in a question, we do have just a few more minutes. I'll just say something while we're waiting for people to type in a question. The tools that shared with us today, many of them can be considered screening. So you're not actually the social worker is not going to be diagnosing and necessarily even assessing, but you're trying to screen to see if this person might benefit from a closer look. And so
right.
I think that kind of puts it, that helps too, that you're just and then if you're using a tool that other people in your facility are using, that your medical director uses, or that the director of nursing is using, that also is a common language and a common way to talk. So that would be the thing that each social worker should do, is find out what other kinds of cognitive screening tools are being used in that facility, and then be able to speak that language with the other folks in there.
That's true, Mercedes. I found that on my very first job, my very first nursing home, the nurses didn't like when the social worker would ask questions or make suggestions to them. Perhaps the resident needs this. And I found that historically, even speaking to some of my professors, they said, well, the social work department and the nursing department never had a great relationship with each other. I am very fortunate where I work now, and I'm extremely close with my nurses, and we act as one. We're always talking to each other. Of course, you've got your daily meetings, too, that we're reviewing everybody. You have a close relationship with your nurses because you're looking at the whole person. So your nurses, your physical therapy department, your doctor, your family. It's a holistic way to treat somebody.
Wonderful. Thank you so much, Byron and Janis, for your time and for sharing your expertise. I just want to let people in the audience know that we will be posting the recording tomorrow, and also the answers to the case study form will be posted as well. So thank you so much for being part of the session today, and we appreciate your feedback. Good, everybody.
Thank you for allowing us the opportunity, Mercedes.
Yes, thank you.
Thank you. All righty.
Bye.